So myself Samrat, and I'm going to talk about the real-world diagnosis of obesity in India, multi-specialty perspectives from a cross-sectional survey. The disclosure is that I am the employee of Eli Lilly and Company, and the authors are also, in addition to one of the author is employee of the Adelphi Real World, United Kingdom. Can you please, next slide is not. Sure, thank you. Yeah, so quickly introduce obesity. As you all know, this is a big public health challenge. There is a lot of prevalence and it is also rising. And a lot of national studies have also shown the same thing. In India, mostly obesity is not considered a kind of disease, mostly a risk factor. And multiple physicians, they encounter the people with obesity. Different specialties have different kind of focus. So there is a need to understand how the different specialties they treat or maybe diagnose the people with obesity. The objective was to describe the approaches to diagnose obesity across different physician specialties. This is also kind of rationale about the study, why we want to know. Diagnostic approaches vary widely across specialties because of the difference in the training, clinical focus, and also varied awareness about the guidelines or the updated guidelines. So we wanted to address this and understand how it is happening practically in Indian market. This is the methodology. So this is a cross-sectional survey conducted by Adelphi Real World from July to December 2025. And this is a secondary analysis of the existing survey, which we had purchased from Adelphi Real World. There is a cross-sectional survey from the physicians, HCPs, and there are 8 consecutive consulting PWO reporting demographics, clinical characteristics, and diagnostic patterns of people with obesity. This is the inclusion criteria. Primary care physicians, internist, diabetologist, endocrinologist, or cardiologist, they were included for this survey. And for the people with obesity, this is the diagnostic criteria: at least more than 18 years of age, actively managed for weight, and not on any of the clinical trials. Analysis were basically descriptive. BMI was calculated using physician reported height, weight from the physician retrospective records, as well as from the recorded diagnosis given by the physician. These are the results. Mostly around 82 physicians, they responded to the survey. It includes primary care physicians 48, endocrinologist 14, internist 8, diabetologist 7, cardiologist 5, and they provided data on 692 people with obesity. You can see this is the subcategory of the different specialties. Mostly 54% of the patients were looked after by the primary care physicians. The mean age is 39 years, almost 38.9 years, and 56% male. The BMI at diagnosis is around 36. Time since diagnosis is 1.4 years. And major comorbidities are type 2 diabetes, hypertension, dyslipidemia. And number of comorbidities or average comorbidities per patient were 2.1. Going to the results of physician perceptions towards obesity and its diagnosis. So when the physicians were asked who they perceive as the specialist in diagnosing obesity, majority of them had indicated endocrinologist and diabetologist, and some 57% also indicated primary care physicians. All the physicians were aware about the BMI, and 92% of all physicians considered BMI as a suitable measure for diagnosing obesity. In the figure 2, you see physicians believe whether obesity is a disease, and majority of them agreed, yes. Is it a chronic progressive disease? Yes. Majority of them strongly agree or somewhat agree. These are the results on diagnostic practices of physicians. So average 5.2 assessments were done per patient. And these are the anthropometric and cardiometabolic tests that have been conducted. So majority of the tests are BMI, height, weight, and waist hip ratio is only 20%. And you can see only 11% waist to height ratio, waist circumference, or the percent body fat. In terms of cardiometabolic parameters, HbA1c, blood pressure, and fasting blood glucose are the major ones. Thyroid function is also conducted 23%, cholesterol level 22%, and triglyceride level 20%, and remaining others are very less frequent. Coming to the BMI and diagnosis of obesity, so we have assessed the BMI diagnosis given by the physician, as well as we also calculated the BMI based on the records, height and weight available for the individual patients. And when we compare them, so 4A shows reported by physician, the BMI at diagnosis, and 4B, the retrospective BMI, which we calculated from the records. So there is a mismatch with regards to the grade 3 and 2 for almost all the categories. If you see, for the total patients, physician diagnosed 27% in class 3, but eventually when we calculated from the records, it came out to be 53%. So there is a mismatch when it comes to class 3 and class 2. Further dig down into deeper into it, so around 39% records aligned with what physicians had diagnosed and what was calculated based on the available data. But almost 55% physicians reported BMI which is lower than the calculated from the records. So discussions. People with obesity were relatively young. It was around 39 years, which indicated a high cardiometabolic comorbidities in the population. And there is a delayed diagnosis and late entry into specialist care. So physicians identified diabetologists and endocrinologists as the specialist. So there is a narrow perception of responsibility at the primary care. And most clinicians only rely on BMI. They never took other anthropometric assessments. Obesity severity was frequently underestimated, especially in the class 2 and 3. There was underreporting by the BMI, advanced BMI categories. So these patterns are highlighting inconsistent, incomplete diagnosis practices, which reinforce the need for guideline-directed assessment of obesity to support earlier and accurate diagnosis. So physician perceptions, that is major challenge here. We need to broaden the responsibility for obesity diagnosis across all the specialties. We need to improve the awareness and use of the guideline recommended anthropometric measures. And there is a need to strengthen the cross-specialty training to reduce the BMI misclassification and support earlier and more accurate diagnosis. Thank you.